Al explorar el mundo, los virus y bacterias aparecen en segundos. Con Similac 3 Kit lo proteges de adentro hacia afuera. Gracias al HMO, nutriente presente en la barriguita de los niños alimentados por mamá, que ayuda a fortalecer las defensas. Protégelo. Ahora es cuando más lo necesita.
Protección y nutrición para sentirse bien.
...120 años de investigación en nutrición, inmunidad y alergia hacen la diferencia. Porque en el bebé con necesidades nutricionales especiales, la primera lección en nutrición va más allá del síntoma físico. Gracias por elegirnos. Nutricia Allergy, transformando vidas a través de la nutrición.
Cordial saludo para todos, buenos días. Agradecerles nuevamente su participación al primer Masterclass Web sobre trastornos digestivos funcionales en pediatría, realizado por el Colegio Colombiano de Gastroenterología, Hepatología y Nutrición Pediátrica. Recordarles antes de comenzar y con el objetivo de buscar una experiencia digital exitosa, los invitamos a que cierren otras aplicaciones en su computador para evitar interrupciones y preferiblemente mantenerse conectados desde los navegadores de Google Chrome y Firefox. Para quienes requieran traducción simultánea para las sesiones de hoy, deben conectarse necesariamente por Chrome. Para familiarizarse con nuestra plataforma, observe que debajo de la pantalla encontrará el programa del evento. También allí encontrará el chat de soporte. En caso de que tenga algún inconveniente técnico, podría notificarlo en esta sección e intentaremos darle soporte. También queremos contarles que allí encontrará el botón de traducción denominado Zoom Translator New Tab y debajo de estos botones encontrará el programa del evento segmentado por días. Queremos también contarles que al terminar esta sección llegará a sus correos una pequeña encuesta para ser diligenciada y en la siguiente semana, después de finalizado el evento, llegará la evaluación final y posteriormente su certificado de asistencia. Antes de continuar con el módulo 5 sobre trastornos funcionales de colon anorrecto, es importante informar que las conferencias de la doctora Sanja Colapset y la doctora Ana María Estallano se dictarán en inglés, por lo cual tendremos el servicio de traducción simultánea para quienes lo requieran. Para ello, les pedimos que pongan especial atención al siguiente procedimiento para que puedan acceder a este servicio.
Para utilizar el servicio de traducción simultánea, por favor seguir el siguiente procedimiento. Primero, es recomendable estar conectados desde el buscador de Google Chrome o Firefox. Después, debe ubicar debajo de la pantalla de nuestra plataforma digital el botón que dice Zoom Translator New Tab, el cual lo llevará al audio de la traducción de Zoom, para lo cual debe diligenciar su nombre en el campo que lo requiere y digitar el código CAPTCHA. podría solicitarle también su correo electrónico. Al ingresar, active el audio de la plataforma de traducción con el botón de compartir audio y con los audífonos. Minimice la página de la traducción y regrese a la plataforma del evento. Debemos silenciar el sonido de la plataforma del evento, para lo cual debe dar clic derecho en la pestaña del Home y buscar la opción que le permita silenciar esta pestaña. Para activarla nuevamente, debe hacer lo mismo. Clic derecho en el Home y desilenciar la pestaña. Con esto usted podrá disfrutar de la traducción. Tener en cuenta que podrá escuchar la traducción desde su celular, pero recuerde que el buscador debe ser Google Chrome o Firefox. Es importante tener en cuenta que el sistema no es compatible con Safari.
Queremos contar que continuamos hoy con la última sesión de trastornos funcionales del colon anorrecto y en la moderación nos estará acompañando la doctora Michelle Higuera. Ella es pediatra y médico cirujano de la Universidad El Bosque, gastroenteróloga pediatra del Hospital Italiano de Buenos Aires, Argentina, e investigador del grupo GastroNutriPet de Colciencias. Maestrante también en educación, profesora asociada de posgrado de pediatría de la Universidad El Bosque. Bienvenida, doctora Michelle.
Buenos días a todos. Hoy damos inicio a esta sesión académica con la charla Brain-Intestine Axis, What is its Impact on Functional Gastrointestinal Disorder, a cargo de la doctora Sanja Kolasek, quien es la actual presidente de la ESPEGA, jefe del Departamento Universitario de Pediatría del Hospital Children's Hospital Zagreb, es gastroenteróloga pediatra con énfasis en nutrición clínica y de enfermedad inflamatoria intestinal. Bienvenida, doctora Kolasek.
Now she's recording.
Dear colleagues, first of all, I would like to express my gratitude to the organizers for inviting me, and also congratulations for having such a good topic. Particularly you in Colombia have so many prevalence data and epidemiological data on the functional gastrointestinal disorder, so my congratulations. I was given the task to talk more about the gut-brain axis. How does it work in functional gastrointestinal disorders? And I will go back almost 5 centuries ago to show you that Shakespeare was the first one to hint that there is a connection between the brain and the gut. In his Comedy of Errors, he said unquiet meals make ill digestion, implying that the stressful life events upon the gut function, and also considering that there must be a gut-brain signaling and the gut-brain connection. So in my talk, I am going to concentrate on it. We will start with the definition of functional disorders, then talk about the potential mechanisms, about the role of the central and the peripheral part, about the role of bacterial content, and so on. But as I said, to start with the definition according to Rome 4 criteria of the functional gastrointestinal disorders, which according to that definition are a combination of chronic or recurrent symptoms after the appropriate medical evaluation has excluded any other medical condition, which means that we did not find any functional or morphological disorder. So it is a normal question that poses every parent, every affected child, but also the doctor, where the pain comes from. And already at the Rome 5 paper, the authors did define that this is due to the changes in pain processing and visceral hypersensitivity. And you can see that this is the main. However, there are many potential sensitizing events which affect upon the gut, and on the other side, also those who affect upon the brain, and particularly upon the sensitive stress recording part, which, as I will talk more, is hypothalamus, hypophysis, adrenal glands. And just to finish this part, to remind all of us that infants, in contrast what I have been taught as a young doctor, that they cannot feel pain because they do not have a fully mature nerve endings. On the opposite, they do have even lower pain threshold. They have this inhibition of descending impulses, and therefore they experience painful stimuli more intensely, completely opposite. And if they, when confronted with a painful stimuli, that this may pave the way to the later development of a visceral hypersensitivity. So if we talk about the visceral hypersensitivity, what could have potentially gone wrong? Is it enhanced afferent pain signaling, or mainly central hypersensitivity to something that is a normal or subthreshold stimuli? Is it a decreased descending pain modulation, or it is something in the autonomic nerve system? We call it a dysautonomia, and we will address it. So by definition, the brain-gut axis means a bidirectional communication which links emotional and cognitive centers in the brain. They belong to limbic system, and it is amygdala nucleus, hypothalamus, and I already addressed it, hypothalamus, hypophyseal or pituitary and adrenal gland axis, which will release cortisol that will affect any segment of the bowel wall, no matter if it is enteric nervous system or muscle layer or epithelium. It will affect motility, immunity, permeability. But there is also a direct communication through the nervus vagus and autonomous nervous system. And it is even much more complicated. It is not only nerves that are in focus. It is from both sides. There are various neuroimmune endocrine mediators which can go different ways in both directions, making them more sensitive to various peripheral inputs. So also something that we were taught previously, that our children with functional gastrointestinal disorders do not have more common psychological disorders, which we would expect if there is such a direct connection between the brain and with the gut. And this was wrong. Today we know that no matter if we are talking about a child or an adult, every second of them also meets criteria for anxious disorder. And I will address just this study, although there are many other studies. These were children from 6 to 13 years old. They were selected whether they were diagnosed with anxious problems, and then the frequency of functional gastrointestinal disorders were determined. And as you can see, 40% of anxious children, compared with less than 6% of healthy children, had some functional gastrointestinal disorders diagnosed following Rome 3. So obviously, being anxious is more common, and moreover, those who were more anxious, according to the to the scores had more severe and were more likely, significantly more likely to have functional disorders. So there is an obvious association between the psychological disorders and the functional gastrointestinal. But the next question is, what starts first? We don't have a good study in children, but we do have good studies in adults. This was one paper summarizing the results of the two studies, one done in the general practice in UK, and those were people who were healthcare seeker, and they came to the healthcare professional with a problem of either anxiety and depression or functional. And the authors of the paper looked what was the first. And as you can see, in 2/3 of these healthcare seekers, the first change was anxiety and or depression. And only in 1/3 it all started with functional problem, and later they developed a mood problem. And the average time from mood to functional was almost 3 years, and from functional to mood, less than 2 years. The other part of this study was to summarize in a population sample what started the first in those who had both problems. And you can see that in almost equal percentage, it started with either functional gastrointestinal and later they developed anxiety, or first with anxiety and later they develop functional gastrointestinal disorder. There is also a meta-analysis looking how commonly will those with anxiety and on the second analysis, depression, later develop functional problem. And the length of follow-up was between 3 months up to, I think, more than 10 years. And you can see that if the anxiety was at baseline, the functional disorder was developed 2.4 times more common than if there was no anxiety. And if depression was there, 2 times more common. So it seems that definitely there is an axis, but it can all start first with brain and then develop in the gut, or it can be vice versa. So there might be 2 different populations of patients. If we go to the hypersensitivity that it starts in the brain, what could have gone wrong? So what could cause the central hypersensitivity, which we define as an increased responsiveness to nociceptive neurons, to normal or sub-threshold afferent input that is coming from the gut? It may be either we have a defect in inhibitory pathways, descending inhibitory pathways, or increased activity of nociceptive pathways, or alteration in the synapses. But not necessarily should there be start in a brain or in the gut. It may also be problem in the autonomic nervous system that connects these two. Our PhD student on my ward is doing the study now, looking and comparing children with IBS with a quiescent IBD, means IBD in a good remission, and the matched healthy controls. They were evaluated how frequently the dysautonomia is present. And as you can see, children with IBS had significantly higher score compared with the quiescent IBD and the healthy controls. Look at the big difference. So it could be that in a subset of patients, dysautonomia is the one that makes us react to the normal or sub-threshold stimuli. Definitely, the problem can be in a gut. So this visceral hypersensitivity may originate because there is a sensitizing medical event, and those here stimuli somehow get amplified. And it can be distension, inflammation, motility problem. it is well known that about every fifth patient with acute gastroenteritis will develop IBS. And we also, according to the studies, know that in children, prolonged infection, prolonged having a fever, younger age, and at baseline, before that, already having the anxiety or depression are the risk factors to develop IBS after the infection. But definitely here, the primary noxious event happens in the gut. And nowadays, we are talking more and more about the dysbiosis, that even no infection is necessary, that the particular altered gut bacterial flora, and you can see it here, so dysbiosis in the gut in a various indirect way, so via the vagus nerve, or direct way by releasing the neurotransmitters by cytokines and hormones, can directly communicate with the brain and set the threshold lower so that we experience something in the gut as a pain. And the more and more we are talking not only on the gut-brain axis, but nowadays in the recent years, you will read about microbiome, gut and brain axis. And there are many studies showing that the gut over the bacteria can talk directly to the brain. In the germ-free animals, also in the patients, we know that patients with autism, schizophrenia, and bipolar disorders do have altered gut microbiota. However, we don't know what is the hen and what is the egg. There are prospective studies in infants and in children showing the association of microbial diversity and temperament, and also inverse relationship between diversity and neural developmental outcome. And I would like to cite a longitudinal prospective study, a selected sample, in those children, a stool microbiota were determined at 1, 6, and 12 months, and that the temperament was determined at 2 years. So even 12 months after taking the last stool sample. And what has been shown, that those who had altered, or we would say problematic temperament, had lower abundance of Prevotella 1 year earlier. So according to these graphs, and that is one of very few prospective studies, shows that there were different microbial content even 1 year before that. So it seems that gut microbiome could be a common denominator of both psychological malfunction and functional gastrointestinal disorder, but yet we don't know what is the type of this connection. In a recent meta-analysis, it just online now, there are clearly shown that there are low fecal lactobacilli, bifidobacteria, and there is dysbiosis in patients with IBS. And the meta-analysis concluded that, however, more quality studies are required to disentangle whether dysbiosis is continuum or it is unique to them. If we say that the microbiome is important, then we can postulate that changing microbiome by different food and by giving probiotics may have some effect on the functional gastrointestinal problems. And there is again a Cochrane review dating 3 years ago, which has shown the role of probiotics, but not food, not FODMAP, not low lactose. We cannot say that they have no effect, but there are no convincing evidence so far. In my ward, we have done a study, a prospective double-blind randomized studies in children 4 to 18 years who were with functional intestinal problems, who were actually pain-related, so functional gastrointestinal pain symptoms, who were randomized to receive Lactobacillus reuteri or placebo. We made an interim analysis because it was difficult to recruit the patients. And after the interim analysis, we finished the study. We have summarized the results because both studies were done after different randomizations afterwards. And as you can clearly see, those who received placebo had less days without pain. So they had more days without pain. And intensity of pain was significantly lower in those who received probiotics compared to placebo. And this difference increased as the follow-up of 4 months increased. They were receiving it for 3 months and was 1 more month of follow-up. But I want to draw your attention to the fact that even the placebo group, after 4 months, the pain intensity decreased almost to the level of significance, which means that placebo can also work. And we know that this is another proof that there is here a central gut axis in case. If microbiome is the common denominator, then we should look the food, how it changes the microbiome, how the microbiome releases active substances, nutrients from the food, and how they can act on this gut central nervous system axis. However, the systematic reviews did not find enough evidence for that. So far, what we can conclude is that, as already Shakespeare said, there is a clear connection between and bidirectional communication between our brain, big brain, and the little brain in the gut. Not only the nervous system of the gut, but the whole intestinal, all the intestinal layers. They are affected by our genetic background and also by the environment. And those stressors can either act more on the CNS or at the periphery, but it doesn't matter where they act. We will finally have a maladaptation of the axis, which is the backbone from the functional gastrointestinal disorders, particularly those who are pain associated. We most probably will have subsets of patients who will start with the central and will later develop peripheral and the other one around. And the common denominator could be a gut dysbiosis, irrespective if the starting symptom is central or of gut origin. However, as you can assume, if we have an IBS with diarrhea and with hard stools, already this can change the flora. So currently, we do not know whether it is just the consequence or it is in this axis involved as a denominator in this axis. And by this, I would like to thank you for your very kind attention.
Conference.
Thank you.
Now we are going to continue with the questions. Buenos días a todos. Vamos a empezar ahorita a responder preguntas sobre esta conferencia. Nos las pueden dejar en el chat y las vamos a ir respondiendo.
Queríamos contarles, antes de que empiecen a llegar todas nuestras preguntas al slide, que en la moderación de hoy también nos estará acompañando el doctor John Garcés. Él es pediatra y gastroenterólogo de la Universidad Autónoma de México, con el Hospital Infantil de esta misma ciudad, y es el actual tesorero del Colegio Colombiano de Gastroenterología, Patología y Nutrición Pediátrica. Bienvenido, doctor Garcés.
Hola, buenos días. Muchísimas gracias. Bienvenida, doctora Sonia, ¿cómo estás?
Hello.
Bueno, vamos a ver qué preguntitas hay por acá. Bueno, doctora, el uso de antibióticos, digamos que ya sabemos muchísimo de que, pues, como tal, pues, impacta muchísimo esta microbiota intestinal. ¿A qué tiempo el uso de antibióticos, el uso de antibióticos cuando uno se los da al paciente, cuánto transcurre para que esa microbiota, digamos, vuelva a estar o vuelva a ser, que no haya sido modificada, que no haya sido impactada por ese uso de antibióticos y no repercuta en ese paciente?
Okay, doctor, can you hear me?
Yes, I can hear
Okay,
you.
hi. The doctor was asking that we know that the use of antibiotics may have an effect on the microbiota. So how long does it affect, how much time do we have to take antibiotics before it starts to affect the microbiota, and how long does it take to regenerate?
Yeah.
And go back to normal?
Yeah, it depends on the type of the antibiotic.
Bueno.
Usually it takes a couple of weeks to get completely to go back. But one important, however, it has been shown, that giving, perhaps you can translate the first part, that it takes usually a couple of weeks. Do you want me to translate? Do you want to wait for the translation, or I can continue?
Perfect.
Okay, but there is one important caveat. You may ask, how can microbiota work and change our sensitivity to gastrointestinal pain and to mood disorder? And one of the way how to do it, a long-term way, is by epigenetics. So I already said in my presentation that it is important that we avoid painful stimuli, but it is also valid for antibiotics in very early infancy, because both, when you make a very painful stimuli in the early infancy, you may somehow predetermine the central nervous system to react even on the suboptimal stimuli afterwards, during the whole life. And the same is with using the antibiotics. So we think that early use of antibiotics changes our flora, but the long run, the flora will go back to normal. However, if you have changed the epigenetics, this epigenetics, despite the flora goes back to normal, can have an effect for the as long as the life is, lifelong effects. So this, no matter if the flora goes back to normal, if there were epigenetic changes, and we today think that epigenetic changes are the way how the flora affects painful stimuli, it will last perhaps even lifelong.
Perfect. Thank you very much. Nos pregunta el doctor Luis Carlos Ramírez, en pacientes sin ansiedad ni depresión, pero con síntomas muy severos de trastornos gastrointestinales funcionales, ¿cómo podemos abordarlos?
Okay, doctor, in patients that suffer from anxiety and depression, but with very severe gastrointestinal functional disorders, how could we approach those kinds of patients?
Yeah, it's a very difficult question, because we have a difficulty of approaching functional abdominal pain and not the children with both behavioral problems, anxiety and depression, and the severe gastrointestinal. So in this case, it is suggested that we act first on the brain, so on the anxiety and on the depression, either with drugs or with behavioral therapy. You are aware, we are aware, we are becoming aware that a so-called hypnotherapy, when you have a functional abdominal pain, even without anxiety or depression, the hypnotherapy is one of the most successful, unbelievable. Even if you are not talking, if you record it on a tape, it works. So this brain-gut axis, if we have the more severe brain, we should go to the psychotherapy and to the drugs. But even if there is only drug, we should try to combine a hypnotherapy or perhaps some probiotics. So there are various subsets of treatment. If we would be very successful, you know, we wouldn't talk that much on it. So we are still at the beginning on the treatment of functional abdominal pain, particularly when they're associated with anxiety and depression. But all those articles that address these two problems say that when you have gastrointestinal, you should look whether it is associated with anxiety and depression, because you have to address this group of psychological problems.
Perfecto.
Okay.
Doctora, por acá preguntan, ¿de forma rutinaria ustedes están utilizando en todos los trastornos funcionales 4 meses de tratamiento de probióticos?
They want to know if, as a routine, you're using 4 months of treatment with probiotics.
No, this was just the study. You know, when we used the probiotics for 3 months and 1 month was follow-up. So altogether 4 months. But if the probiotics work, really, if they work, I use it. You know, I don't just use it 3 or 4 months.
Okay.
I continue using it.
Perfecto. Nos preguntan cuál es su opinión sobre el sobrecrecimiento bacteriano intestinal y el síndrome intestino irritable. ¿Cuál sería su tratamiento? ¿Cómo lo trataría?
Okay, what's your opinion on overgrowth, on bacterial overgrowth and IBS? How would you treat it?
Yeah. When we talk about the bacteria and microbiome, yes, we think that it is the possibility of small intestinal bacterial overgrowth. So how do you treat it? Usually when you have a severe disorder, you treat it with antibiotics that which are preferably not being absorbed from the gut to the, but you can treat it also with FODMAP diet, or you can try to treat it with probiotics as well, because we would like to skip antibiotics. So when we have a small bacterial overgrowth in short gut patients that makes a severe problem, yes, then we give antibiotics, preferably, as I said, those who are not like rifaximin, who are not absorbed from the gut into the blood. But in those functional abdominal pain, we are not prescribing antibiotics. We would like to change it by food, or by changing a diet, or by giving probiotics.
Perfecto.
Perfecto.
Doctora, sabemos que esos cuadros gastrointestinales agudos, diarrea aguda, causan síndrome de intestino irritable. ¿Cuánto tiempo recomienda usted para usar probióticos en esa etapa o en esa fase aguda de infección para evitar, digamos, llegar a un intestino irritable o problemas gastrointestinales funcionales?
Okay, we do know that, for example, severe problems like diarrhea may cause an IBS. So how would you treat them with probiotics, or what kind of treatment would you consider to avoid prescribing antibiotics, or to avoid a future IBS?
Yeah. To be honest, I'm not aware, although I am following the literature, I'm not aware that there are good studies by randomizing those who had acute diarrhea, acute infectious diarrhea, that were randomized to receive probiotics versus placebo, followed up long enough to see whether the frequency of functional disorders of IBS differed. So I'm not aware of it. And without that good study, randomized, prospective, double-blind, we really cannot say. Perhaps you know if there is such a study, but I'm not aware of a good study that has done it.
Thanks. Nos pregunta el doctor Andrés Enríquez, para minimizar la alteración de la microbiota con uso de antibióticos, ¿recomienda siempre el uso de probióticos?
Okay, to minimize the alteration of the microbiota with antibiotics, do you consider the regular use of probiotics?
No. Definitely with some bacteria like Clostridium and so on, by using probiotics, definitely you can make a benefit. However, you may, just to be more clear, that by using probiotics after and along with antibiotics, we may decrease some complications such as getting the Clostridium difficile diarrhea, or we can minimize the diarrhea associated with antibiotics. However, in healthy children, acute infective diarrhea is a short, self-limited disorder. So giving probiotic, having this in mind, I'm not in favor to regularly giving probiotics to prevent this gastrointestinal disturbance during the antibiotic therapy. So not regularly and not in all children. However, there are children with chronic gastrointestinal disorders. There are children who are more prone to developing Clostridium difficile after use of antibiotics. And in that case, probiotics may be beneficial. So you always have to see whether, acute gastroenteritis happens commonly, it is self-limited, it lasts for 2 to 3 days. Why do all the kids give probiotics? So you need to find the niche, those children in whom you do expect and you don't want to have diarrhea associated with antibiotics, and particularly diarrhea caused by Clostridium difficile.
Ok, perfecto.
Doctora, ¿existe alguna relación entre el desorden eje cerebro-intestino y el riesgo de enfermedad inflamatoria intestinal?
Okay, doctor, is there a relationship between the brain-gut axis and the risk for an inflammatory bowel disease?
Good question, because we say we are now looking at all what is happening in early infancy, in using of antibiotics, in the consequent initiating dysbiosis in these early ages and later development of IBD. Also, there are data showing that breastfed babies, and what the mother or what hundreds of anti-inflammatory mediators, anti-inflammatory mother's milk is providing. So we may say that lack of mother's milk, the inflammatory status is increased, and that this may pave a way, most probably by epigenetic mechanisms, to later development of IBD, but we don't, although there are data connecting the type of food, also the early gastrointestinal infections with later IBD, we don't have a clear pathogenetic way out of it. We can only say it's a risk factor, but we don't have a clear answer.
Ok. Nos menciona el doctor Álvaro Mariño, excelente conferencia, y su pregunta es: ¿condiciones socioeconómicas con medio ambiente desfavorable en cuanto a dieta, contaminación, aumenta los trastornos gastrointestinales funcionales y cuáles?
Okay, what socio-environmental conditions like the diet, etc., can increase functional gastrointestinal disorders?
Yes, definitely. Socioeconomic factors do play. If you remember the study that I have shown, the study how common gastrointestinal pain disorders are, functional disorders are in those who are children, 6 to 13 years old, who had anxiety and depression. And you have seen that almost every second child with anxiety and depression had a functional pain disorder. And what I haven't had enough time, this was even much more pronounced, significantly more pronounced if they were coming from the low socioeconomic background. So the low socioeconomic background made an impact that the gastrointestinal problems were more frequent and more severe in those who were already depressed and with anxiety. So it makes an effect, definitely.
Ok. Bueno, tenemos la última pregunta. El doctor
This is our
Bea,
last question.
¿tiene alguna experiencia, doctora, en la estimulación auricular para los trastornos funcionales gastrointestinales?
Do you have any experience in auricular stimulation for functional gastrointestinal disorders? I think it's in the ear.
Ear, auricular. No?
Auricular.
No?
No.
Do you have? Now the
No.
contra question. Do you have?
¿Cómo? No.
Okay.
No.
Okay. Thank you.
Okay.
It has been a pleasure.
Thanks, doctora.
Sí.
Continuamos con la charla Functional Constipation. Is there something new? A cargo de la doctora Ana María Estallano, quien es catedrática de pediatría, tesorera de la Sociedad Europea de Gastroenterología, Hepatología y Nutrición Pediátrica, vicepresidenta de la Sociedad Italiana de Pediatría. Bienvenida, doctora Estallano. Good morning, doctora Estallano.
Good morning. It's a pleasure for me to present this talk, and I thank all the organized committee of this virtual meeting for inviting me for this presentation. In this presentation, I will go over the epidemiology and pathogenesis of functional chronic constipation. After that, we will look at some note on diagnosis, and then finally, I will finish with some report about therapeutic management. In this slide, we can see a systematic review and meta-analysis on the prevalence of functional defecation disorder in children, and we can see that the prevalence among children is ranging from 0.5 to 32.2%. So is really variable among the different countries. In this slide, we can see the prevalence of different functional GI disorders, and we can see that functional constipation is a very frequent disorder from the first month of life until the late adolescence, differently from other disorders which are more frequent in specific time of the life. Functional constipation is characterized by a low quality of life. In fact, many studies reported a lower health-related quality of life regarding disease-specific emotional and social functioning. On the other hand, functional constipation imposes higher medical care costs. In fact, children with constipation used more healthy service than children without constipation, resulting in higher costs. We can see more than $3,000 per year in chronic constipation children versus 1,000 in normal children. Quality of life in children. In this recent systematic review and meta-analysis, it has been reported that the mean total pediatric quality of life score is below the reference values, both reported by parents and by the children. So we can see that all these studies report a low quality of life in children with functional constipation. What about the causes of functional constipation? In this recent report on management of functional constipation in children and adults, the causes are referred to an abnormal afferent and efferent pathways. There is an abnormal interaction between the brain and the gut that may be caused by behavioral disorders, psychological disorders, lifestyle factors such as diet, fluid intake, obesity, or impaired anorectal function. On the other hand, we can have that stress and stressful life events may start functional constipation, as well as parental factors, disrupted microbiota. Recently, genetic factors have been implicated in the pathogenesis of functional constipation, as well as colonic dysmotility. In this recent study, it's very nice, this cartoon that reports the functional constipation vicious cycle. In your left, you can see the pathogenesis of acute constipation. Then on your right, you can see how this acute vicious cycle will determine chronic constipation. At first, we can have that there is a fecal retention and the stool dries up. This will generate pain when there is the passage of hard rock-like stools. When there is pain, the child starts to withholding in the order of to suppress the defecation for the fear of pain. So to avoid painful defecation, there is this there will be a retentive posture, so a withholding that brings up again to difficult evacuation and constipation. This that will determine an impaction of stools with a chronic distended rectum, then megarectum, with a loss of muscle contractility. This will create, will generate a stool of huge calibre, then will worsen the pain during the elimination of these hard, large caliber stools. This pain during the defecation will determine a chronic withholding leading to loss of sensitivity and further constipation. In fact, in this slide, we can see that the pain-related etiology has been reported in 63 children with fecal incontinence. It has been reported that at least 63% of children with fecal incontinence had at least one painful defecation in the first episode in the first 3 years of life. So this will determine a pelvic dyssynergia, the inability to evacuate, to defecate during efforts to defecate. So this has been reported in 52% of children with constipation. And this will contribute to the fecal retention, which is the cause of megarectum with further fecal impaction from prolonged rectal distension. And megarectum is the first step before the megacygum or the functional megacolon. In these slides, we can see the causes of chronic constipation in children, and even if is a very common chronic constipation, we can see that functional chronic constipation is the most common cause of constipation in children. Nevertheless, we need to rule out other causes of organic constipation, such as anorectal malformation or alteration of neuromuscular intestinal structures, such as Hirschsprung disease, or rule out endocrinologic and metabolic disorders or neurological and neuromuscular disease. It's very common to find children with cerebral palsy with severe manifestation of constipation. Or constipation may be a side effect of medications such as anti-acid, anticholinergic, anticonvulsivants, or bismuth. How we define functional chronic constipation based on Rome criteria, and in 2016 the new Rome criteria were published. We had in gastroenterology 2016 two chapters, one dedicated to the definition of functional GI disorders in infant and toddlers, and one in children adolescents. The difference between Rome 4 and Rome 3 criteria were not very significant. In infant toddlers, the only change was that the elimination of episodes of incontinence in infant and toddlers, and in children and adolescents, the only modification was in the duration of constipation, that was decreased for 2 months to 1 month. In these prospective studies, our group evaluated the ability, if the application of Rome 4 criteria would decrease the frequency of chronic constipation, would decrease the diagnosis of functional constipation in children. But we found that the correlation with the Rome 3 criteria was at a good agreement. So we can see that applying both Rome 3 criteria or Rome 4 criteria, the total in the number of diagnoses was pretty similar. So with a very good agreement. The diagnosis of functional constipation is based mainly on a detailed clinical history and an accurate physical examination. A detailed history which include the age of onset of functional constipation, the presence of fecal incontinence and large stools. If we have a child with fecal incontinence and large stools, most probably this child will be affected by functional constipation. At physical examination, in children with functional constipation, it's very frequent to have abdominal mass, and in children with functional constipation, the anal inspection should be normal, and we need to exclude occult dysraphism. And when there is an alliance between the physician and the child, is accurate to have a rectal examination showing in children with functional constipation stools in the rectal ampulla. However, in order to make the diagnosis of functional constipation, it is important to rule out alarm signs. These alarm signs include a long list, but I read just some of these, such as constipation start very early in the life, in the first month of life, the passage of meconium later than 48 hours, or a family history of Hirschsprung disease. In this condition, we can suspect an Hirschsprung disease. Otherwise, If we have a child with ribbon stools, most probably we can have an anal malformation, like as a substenosis. Or if we have severe abdominal distension, we have to think about an organic cause of constipation. In case of tuft of hair on the spine or gluteal cleft deviation, we should think about an abnormal spinal tract in these children. However, when we have some red flags suggesting an organic cause, we should send this child to a specialist in order to exclude organic cause. And one of the first procedure that we can suggest is represented by the anorectal manometry, which can be confirmatory investigation to exclude Hirschsprung disease, especially in older children with constipation since infancy. However, I want to underline, according to this practical guide for the diagnosis of primary enteric nervous system disorders, based on recommendation from MESPGAN, European Society for Pediatric Gastroenterology and Nutrition, and NASPGAN, North American Society for Pediatric Gastroenterology and Nutrition, barium enema should not be the first diagnostic investigation in case of suspected Hirschsprung disease, but we have to suggest barium enema after the diagnosis of Hirschsprung disease to evaluate the length of aganglionic bowel. So how we should make the diagnosis of Hirschsprung disease? Based on the same practical guide, we can see that the gold standard to make the diagnosis of Hirschsprung disease remain the rectal suction biopsy with a very high sensitivity and specificity. But on the other hand, we can see that the manometry also has a good sensitivity and specificity to support the suspect of Hirschsprung disease. And let's move to the treatment of functional constipation, which include both non-pharmacological treatment and pharmacological treatment. I will go over some of these. Let's start with non-pharmacological treatment, and in this slide you can see the recommendation of the combined guidelines ESPRA and NASPRA on functional constipation in infant and children. What is the additional effect on non-pharmacological treatment in children with functional constipation? The recommendation based on evidence-based studies on the expert opinion are all summarized in this slide. It is recommended a normal fiber intake in children with constipation. Fiber intake, a regular fiber intake may prevent the appearance, the presence of functional constipation, but excess fiber by itself cannot treat functional constipation. It's recommended the normal fluid intake in children with constipation. If we increase the fluid intake, it has been demonstrated that the urinary fluxes increases, there is not an increase in bowel frequency. It is recommended a normal physical activity, and it is not recommended the routine use of prebiotics and probiotics in the treatment of a child with constipation, since the evidence are still scarce. I will go over because I'm afraid that I am a little late, and I want just report some study studies on the use of fibers in the treatment of functional constipation. Usually we suggest to use prunes or kiwi fruits to improve bowel habit. But in this slide, in this study on alimentary pharmacological therapy, it was reported that although prunes may be a promising intervention for management of constipation and increasing the stool weight, this needs to be confirmed by further research. And it is the same for kiwi fruits. There are some studies evaluating the effect also in the randomized double-blind placebo-controlled study on the efficacy of some kiwi proteins in improving the stool frequency. But at the end of this study, it was reported that there were no significant differences between intervention for bowel movements and Bristol stool scales in constipated children when treated with kiwi supplement of kiwi fruits or placebo. In this study published from our group in Journal of Pediatrics in 2012, we evaluated the efficacy of a mixture of soluble fibers such as acacia fiber, psyllium, and fructose versus polyethylene glycol in the treatment of functional constipation. And we found that the effect was completely similar with no significant differences. And we found that this result was very important since polyethylene glycol is considered the gold standard for the medical treatment of functional constipation. In fact, in this slide, we can see the recommendation from the combined ESPGHAN-NASPGHAN guidelines, and we can see that for this impaction, in fact, we know that in the treatment of functional constipation, we have the first two phases that include the first phase, the disimpaction, the elimination of the rectal impaction, and then we have a maintenance treatment. So let's start with disimpaction. Evidence support that polyethylene glycol with or without electrolytes at a dose of 1 or 1.5 grams per kilo per day for 3-6 days are the first line treatment for children presenting with fecal impaction. However, the same efficacy is reached by enema once per day, a day for 3-6 days. So with the similar efficacy. What about the maintenance treatment? The gold standard is represented by solution of polyethylene glycol with or without electrolytes, starting with a dose of 0.4 gram per kilo per day, and this should be adjusted according to response. This means that we have to reach that the child will present at least one soft stool per day in order not to have the pain during the defecation. In the countries where PEG, polyethylene glycol, is not available, lactulose at a dosage of 1 or 2 grams per kilo per day is the best medical treatment in children with functional constipation, whereas the use of milk of magnesia, mineral oil, and stimulant laxative represent second-line treatments. However, the success rate of polyethylene glycol in constipation children range from 56% to 83%. So we have 17 to 44% of children with functional constipation who do not respond to the gold standard medical treatment represented by solution of PEG. So we have to look for new emerging drugs for constipation, and for sure there are some that have been tested in the last few years, such as prucalopride, which is a 5-HT4 receptor agonist, or lubiprostone and linaclotide, which both act on the chloride channel activation, which with a secretion of water in the lumen associated also with secretion of chlorum. And I will go ahead. In this study, a multi-center study published in Gastroenterology 2014, prucalopride, although generally well tolerated, was not more effective than placebo in children with functional constipation. There are other studies going on the efficacy of these drugs in children, but we are still waiting for the result. For lubiprostone, this is the only study up to now in as an article in JPGN 2014, where is always a multi-center open label study, where we can see that the primary endpoint was the spontaneous bowel movement frequency during the week 1 versus baseline, and the conclusion was that lubiprostone was efficacious and well tolerated in children and adolescents with functional constipation. But and this is the linaclotide, but I will go to the end with the take-home messages. Functional constipation is one of the most prevalent functional GI disorders, with an high cost and low quality of life in affected children. The diagnosis is mainly based on the clinical history and physical examination, with the identification of red flags or alarm signs. The medication of first choice for both disimpaction and maintenance treatment is represented by polyethylene glycol. Over the next years, a new pharmacologic agent will be approved also for the treatment of childhood constipation, and we will, once they will be available, we can have also them in the therapeutic armamentarium of these functional disorders. Thank you for your attention.
Doctora Tayano, excelente conferencia, muchísimas gracias. Bueno, tenemos bastantes preguntas. Yo quisiera empezar por una, y es por el examen físico. Muchos niños, cuando les llegan a la consulta, llegan ya con múltiples enemas, con múltiples revisiones de la zona anal. Digamos que por lo menos yo rutinariamente no lo examino, porque a veces es más la pelea con ese paciente y más la aprehensión que tiene el paciente. ¿Ustedes recomiendan sí o sí obligatoriamente examinar el recto, hacer tacto anal, o lo podrían dejar para una siguiente consulta cuando uno tenga más confianza, cuando el niño baje un poco la aprensividad, o lo hacen en el rutinario?
Okay, doctor, can you hear me?
I can hear you very well.
Great.
Can you
Yes.
hear me?
Yes. The question, doctor, is that many times when the kids arrive to the office, they have already undergone plenty anal examinations. They have undergone plenty enemas. So do you think that when they come to you for the first time, is it better to do another enema, do another exam, or is it better to wait until there's more bonding with the kid?
If we are in front of a child with functional constipation, no test is indicated. We have to better understand the clinical history the compliance with the medical treatment, because many times they are in treatment from long time, but at a low dosage. And sometimes parents are afraid to give every day the drug, and so sometimes they use every other day at a low dose. So I believe the first important thing is the clinical history and the physical examination. It's very important to know if they eliminate huge stools. Sometimes parents complain about the diameter of the stools that are very large. And I always say, if they are large and if the child present fecal incontinence, this means that the distal intestinal tract works well, and so most probably we are in front of a functional constipation. At this point, we have to suggest a new management plan. Okay.
Okay.
Perfect. Excellent conference, doctora Stayano. Nos hacen otra pregunta y es, la doctora Claudia pregunta, ¿cuándo y a qué edad sugeriría el uso de prucalopride y en qué dosis y por cuánto tiempo?
Okay, when, at what age would you suggest the use of prucalopride, in what dosage, for how long?
Up to now, there is just one study on prucalopride in children. And this is a multi-center study, and the effect was not completely as expected. So I would suggest to use prucalopride in front of refractory constipation, when we are sure that we are dealing with a functional constipation not responding to the gold standard treatment that is represented by polyethylene glycol. Honestly, in my experience, I use just in adolescents when they don't want to have large dose of polyethylene glycol and they want just to take pills. Okay, but it's very uncommon that I suggest to use prucalopride for now, because I am waiting for new studies in children. Okay.
Doctora, ¿tiene alguna experiencia de neuroestimulación sacra o tibial posterior?
Do you have any experience in neurosacral and tibial neurostimulation?
Yeah, I can understand sometimes some Spanish, even if I don't speak Spanish. Personally, I don't have experience, but for sure in the last few years there are so many studies in neurostimulation, and there are especially the group from Carlo Di Lorenzo, Miguel Zapp, and so on, Mark Beninga, they used. But I believe that also this kind of treatment is still ongoing to be used by routine, because for sure in some ways it's still a little invasive, because you have to put the subcutaneous electrodes, and these kind of treatments are recommended especially in children with fecal incontinence, with severe fecal incontinence.
Ok, perfecto. Nos preguntan, ¿el estreñimiento funcional se hereda?
Is functional constipation inherited?
This is a good question. It seems that in some parents refer that especially mothers have been constipated in the past. There are few families where it is reported, the association, but really up to now there are not
identified polymorphisms associated with functional constipation in children. For sure, we have to consider that the diet is important, is one important component in the pathogenesis of chronic constipation. And we have to think that in the same family, usually the diet is similar. So maybe this may play a role in having the same disorder in the same family.
Okay.
Doctora, ¿cuándo considerar los enemas anterógrados? Y si al usarlo se puede adicionar bisacodil o PEC para mejorar la respuesta.
The usage of anterograde enemas.
Yeah, once again, anterograde enemas we use for real severe cases with fecal incontinence and also with spinal lesions, myelodysplasia, spina bifida, when, there is for sure a severe neurogenic disorder, and in this case we need to be more aggressive in the treatment.
Ok. Otra pregunta que nos hacen en cuanto al bisacodilo y el manejo prolongado, o por cuánto tiempo se podría indicar.
The extended management of bisacodil.
Bisacodil, you say, stimulant laxative are not recommended for long time in children, because we know that they can have side effects such as melanosis coli that in animals have been associated with a worsening of chronic constipation. So when other treatment options do not work in the combined aspirin-aspirin guidelines, it is recommended, as I reported in one slide, stimulant laxative as a second option for short period of time.
Okay.
Doctora, en esos pacientes que no tienen historia de estreñimiento, adolescentes o escolares, que hacen una constipación aguda, o sea, hacen una impactación aguda y que, digamos que no tienen ningún factor de riesgo al parecer y que posterior presentan un estreñimiento de difícil manejo, esos pacientes, digamos que se les debería descartar y cómo sería el tratamiento de elección, porque digamos, a pesar de tratamientos con laxantes, enemas, son pacientes que no evacúan, supremamente distendidos y permanecen pues así muy largo tiempo.
Did you get the question?
No, in some way, but not.
Okay, in kids or in children or in adolescents that come in with very acute constipation, like they have an acute constipation, but there are no other risk factors, what kind of management would you suggest? But there's nothing else, only acute constipation.
Acute constipation, first of all, I would suggest a more accurate diagnosis, such as a plain abdominal X-ray to see if there are abdominal fluid levels. And if there are just stools, I believe that it is important to insist with large doses of polyethylene glycol, because we know that the average dose is 1 milligram per kilo per day. But if we want to have a complete disimpaction, we have to use large doses, sometimes parents complain that they use a lot of drugs, a huge amount, but they do not have bowel movements. In some selected cases, we have these patients as inpatients, and we perform the treatment in the hospital, and we give large amount of polyethylene glycol, and usually we are successful with this, okay?
Ok, doctora, ¿y cuál es la dosis máxima que ha utilizado de polietilenglicol oral, obviamente?
You know that there are studies where polyethylene glycol has been used even with dose higher than 3 grams per kilo for cleaning, for colonoscopy. We don't use this kind for constipation, but for sure we use 1.5 gram per kilo for 6 days, and if it does not work after 1-2 days, for sure we have good results after 3-4 days, because sometimes polyethylene glycol takes some days before to have the first effect. So we have also to explain to the families that they have to wait for 1, 2, 3 days until they will have the first huge effect of the drug.
Perfecto. ¿Y la dosis del PEC la prefieren una sola toma al día o fraccionada?
Usually I prefer to give in one dose, also to avoid the risk that the second dose will not be administered. So you can give in one dose, and I believe that the effect is even better, you know.
Listo, perfecto.
Okay.
Doctor Estallano, muchísimas gracias por estar aquí con nosotros el día de hoy, despejarnos todas nuestras dudas.
It was a very big pleasure for me to stay with you, and congratulations for an excellent organization of this virtual meeting. Really, congratulations. I'm sorry that I cannot be with you, because I would have loved to visit your beautiful country. I have never been, but everyone said it is fantastic. But congratulations for the organization.
Thank you.
Thank you very much. We hope to see you soon here in Colombia.
Thank you. Thank you. Bye. Thank you for the invitation.
Muchas gracias, doctor.
Okay.
Bueno, los invitamos. Bueno, muchísimas gracias por su asistencia. De verdad, un placer estar con Michelle el día de hoy. Mucho, ¿no, Michelle?
Muchas gracias a todos, agradecemos a los invitados que tuvimos en el día de hoy y a todos ustedes por haberse conectado a este espacio, y los invitamos nuevamente a nuestra próxima sección el próximo martes 20 de octubre a las 7:30 de la noche. Los esperamos a todos, feliz fin de semana, que descansen.
Chao, chao, muchas gracias.
Chao, hasta luego.
120 años de investigación en nutrición, inmunidad y alergia hacen la diferencia. Porque en el bebé con necesidades nutricionales especiales, la primera lección en nutrición va más allá del síntoma físico. Gracias por elegirnos. Nutricia Allergy, transformando vidas a través de la nutrición. 120 años de investigación en nutrición, inmunidad y alergia hacen la diferencia. Porque en el bebé con necesidades nutricionales especiales, la primera lección en nutrición va más allá del síntoma físico. Gracias por elegirnos. Nutricia Allergy, transformando vidas a través de la nutrición.